Oh, I don't know as many.
One of the goals of this conference is not only to have a vision of where we're going in terms of what ideal pain management might look like, but it's also to give you some nuts and bolts management best practices that are going on now in various different areas in Montana. So what we've asked the speakers in the afternoon to do is to try to give us some pearls and bring together some of the various different tools that we have in that toolbox to bring to bear on chronic pain. Now, one of the problems that I see with chronic pain management that Dr. Rudin tended to focus on for a moment, and that is this myth, this urban legend, that chronic pain management equals opioids. And unfortunately, in some of these discussions that we have, conferences we have, what it devolves into is a discussion about how to prescribe opioids, the problems with prescribing opioids, and the complications of prescribing opioids. Quite frankly, that's not what chronic pain management is all about. And chronic pain management, from a functional restoration standpoint, has so many other facets to it, which include what we can do to people, such as give them medications, give them injections, even do surgery on them, to the point to where we begin to teach them what they can do for themselves. And I constantly am telling patients that come into our clinic, you know, we can do all these things to you, but the sooner you make the transition to understanding what is within your power to control, the better off you're going to be, and the more likely you're going to be to have a good, solid chronic pain management program that you can go into the future with and really benefit from. So this afternoon, you're not just going to hear about how to prescribe X pill and what X pill does and the problems with prescribing X pill. You're going to hear speakers talk about a true multimodal approach to chronic pain and what the benefits to that are. Now, we're going to kick off the afternoon with discussions on analgesics. It's really the pharmacological approach to chronic pain management. And Leanne Bradley is going to give the next talk. Leanne is a clinical professor at the University of Montana School of Pharmacy, and there's a lot of pharmacists in here. My understanding is that she essentially has trained every pharmacist in Montana, because when they call, they don't call for anybody else, they call for Leanne in our clinic. So I think she has touched the lives of every pharmacist and probably a lot of nurses and a lot of medical students that have come through Missoula. She also is in charge of our pharmacology program at the Montana Spine and Pain Center, and also is in charge of the acute pain service at the St. Patrick Hospital. So a ton of experience, and she has really made our program what it is today in large part. So with that, I'll turn it over to you.
It's always challenging to be the first speaker after lunch. I'll try really hard not to put you to sleep. Can you hear me? Okay. I do teach pharmacology, and I was pleased to ask to be able to present here. And then I found out I have to do an overview of all the analgesic pharmacology in 30 minutes to a very diverse group with very differing backgrounds and knowledge bases, which I found very challenging to write this. But what I thought I'd do then is stand back and look at an overview of how do you select a medication for a patient in pain? So that's the way I was going to approach this. Our patients come to us generally after going from one provider to another provider to another provider, or one treatment to another treatment to another treatment, until somebody gives up. And when you think about it, I borrowed this slide from Dennis Turk out of the University of Washington, which he presented at a conference I was at last year, looking at all the different reviews of all the different drugs and all the different all the different pain syndromes, and global overview of how well drugs work in pain management. And although they do hold a central position, they are a very good tool we can use. They're not panacea, they're not cures. On average, they only reduce pain by about 30% in 40 to 50% of patients. So that slide of patients, trying one thing and then it didn't work, and then the next one and the next one, it kind of makes sense in the pain management world when you're looking at drugs, in that we don't have a magic bullet that's going to fix our patient to give them zero pain and return them to how physically active they were when they were 18 years old. That just doesn't work. And yet patients do come to us, and most patients come with the expectation of receiving a medication, which we then have to work on expectations of what's reasonable. So picking a medication, Dr. Rudin explained this morning, there's somatic, visceral, and neuropathic pain. Hopefully there's a really good assessment done first to look at what it is we're treating, because we're going to pick different drugs based on what is the patient presenting with. The somatic pain, the skeletal muscular pain, and often the bone pain, does respond really well to opioids and non-steroidal anti-inflammatories. So those are generally your first-line agents. Generally, your skeletal muscle pain and your bone is more acute pain, although your bony metastases will be longer. But these are pain syndromes that really do work well being treated with opioids and non-steroidal anti-inflammatories. Additionally, there's other weapons, like for vertebral fractures, for one of these, the calcitonin is one of the older osteoporosis meds, has shown good pain relief acutely in like new onset fractures. The biphosphonates, can't stress how much important it is to prevent new fractures in patients in whom their chronic pain syndrome is affecting the strength of their bones. And then steroids for bony metastases and palliative radiation works really well. I threw this slide in on muscle spasms because I've seen so many patients in the hospital get really, really sedated on opioids when the assessment reveals that it's muscle spasms they're having. And the muscle spasms don't respond well to opioids, even though it's skeletal pain. And there's other drugs to use for muscle spasms. And most of these drugs, though, are recommended just acutely. Over time, they tend to be more tranquilizers. Cyclobenzaprine doesn't quite fit into that. It's actually structurally related to tricyclic antidepressants, and it has a place with fibromyalgia. But most of these you only want to use acutely. And the soma, the risperidol, we never use that one. It is metabolized to a major tranquilizer, meperamate, which basically went out in the 50s. The visceral pain that was discussed this morning is a little bit more difficult to treat. And it doesn't respond as well to opioids. Doesn't mean you can't use them, but a lot of times nerve blocks like celiac plexus blocks for pancreatic pain are much more effective. Sometimes you have to resort to intrathecal opioids and epidurals. Octreotide is something that decreases stomach acid that's used for bowel obstructions so that the secretions don't distend the GI tract and cause a lot of pain. And that would be something palliative care could be using. And the antispasmodics, there are antispasmodics that do work for the skeletal, for the smooth muscle, visceral organ pain. They don't always work great for irritable bowel, but they can be helpful. And the opioids are basically contraindicated in irritable bowel syndrome for most patients. This is my favorite slide for neuropathic pain, the 2000 Bitterroot fire. Yeah. So the neuropathic pain talked about and described abnormal nerve functioning. The other thing I didn't mention is one of my many character flaws is I always put too many slides into lectures. I think everybody wants to know as much as possible. So there are a lot of extra slides in here for those of you who want to look at them later. But we are, because it's going to be 30 minutes, going to have to skip some of these. But like the neuropathic pain was already discussed, your first line agents, there are two groups. One is the anticonvulsants, and the other is the tricyclic antidepressants, or the antidepressants with tricyclic antidepressants and the serotonin norepinephrine reuptake inhibitors. Those are your two main groups to treat neuropathic pain. There's good data to support these drugs for treating neuropathic pain. And I don't know how many times patients have been given a prescription for something like amitriptyline, tricyclic antidepressant, and when they find out, when they go to the pharmacy and they get the handout and it's called an antidepressant, and they're not depressed, that they refuse to take it, and they're angry, and they just, the trust that is blown with the provider that wrote this prescription, because they think it's all in their head and they just think they're depressed and they're giving them this prescription. So the patient's expectations and education and understanding why they're being prescribed these drugs is really important. These are your first line drugs for neuropathic pain control. The tricyclic antidepressants are no longer used a lot for depression because of the side effect profile. There can be, like with these first generation ones, the amitriptyline, imipramine, a lot of anticholinergic side effects. So they're actually not recommended in elderly patients. Orthostatic hypotension, they can fall, then they break their hip, then everybody's unhappy. But you can go to the second generation ones. A little less literature to document benefit, but they are beneficial, and they have less anticholinergic side effect. And the other good thing about these drugs is we don't need full antidepressant doses to treat neuropathic pain. Most of our patients are on less than 100 milligrams a day. They're not going to have therapeutic blood levels for depression treatment. The other nice thing about these drugs is if you do have a patient with refractory depression on a different antidepressant, you can add a small dose of these usually at bedtime, and it can be an adjuvant for the depression and treat neuropathic pain without getting into the full side effect profile. Duloxetine has good data for treating neuropathic pain and generalized pain associated with depression. Venlafaxine is in that same norepinephrine serotonin reuptake inhibitor group, but it doesn't tend to be a balanced norepinephrine serotonin reuptake inhibitor. It tends to be mostly serotonin until you get to the real high doses, like 225 milligrams a day. Then it gets a little bit more balanced. The benefit to it is it's generic, more affordable, and it does have some data to support it. Overall, the SSRIs, the most common antidepressants, the Prozac, Zoloft, Celexa, Lexapro, are ineffective for neuropathic pain. And patients will repeatedly tell me they were put on the Prozac for their diabetic peripheral neuropathy or whatever. It is not, these drugs are not effective in those conditions. It gets more complicated if they have depression. Depression definitely lowers pain thresholds, definitely makes people hurt more, definitely makes people cope less well with pain. So it's very important to treat depression, and they overall feel better, but by themselves, they do not treat neuropathic pain. There can be steroids used depending on whether it's like an acute low back injury where you irritate your sciatica nerve. But steroids for chronic neuropathic pain are ineffective. Capsaicin is the hot pepper cream. It can be challenging to use. People, they have to take their shoes off 3 times a day. They have to use rubber gloves. They have to apply it. They can't touch their eyes. It takes 4 to 6 weeks to work. It is effective, but compliance is an issue with this one. Lidoderm patches can be very effective depending on how big of an area you have to cover. Opioids in neuropathic pain can be effective. They can be as effective as all your other drugs, your first line agents. They're just generally listed as second or third line because you want to maximize those other effective drugs first. Neuropathic pain can be very difficult to treat, and you're not going to get a total response with an opioid, and it usually takes a higher dose. And so the tendency to try for a patient to try and keep pushing that to get total control is going to be higher if you start with the opioid as opposed to starting with your adjuvants and getting as much pain control possible, if possible. With really severe neuropathic pain associated like with acute herpes outbreak, I wouldn't recommend withholding the opioid. You're going to increase the chances of having postherpetic neuralgia if you don't aggressively treat that up front. But in the chronic situation for neuropathic pain, you generally consider these opioids as second or third line after you get your maximum benefit from your other drugs. We talked about this morning the central nervous system, the alpha-adrenergic agents. You can, for sympathetically maintain centralized neuropathic pain, add an agent like clonidine. It can downregulate the nervous system, decrease sensory input. The skeletal muscle relaxants that I did not list on the previous slide, these are actually alpha-adrenergic agonists. They're very effective for the spasticity associated with conditions like multiple sclerosis. They also can be used for chronic pain in downregulating that nervous system. And so these can be used long-term if they're effective. When we talk about picking a medication for a patient, then besides what kind of pain they're having, that you consider the comorbidities. It's really nice if you can pick one drug that treats 3 conditions like depression, insomnia, and neuropathic pain with a tricyclic antidepressant given at bedtime because the main side effect is drowsiness and they sleep. So it's nice when you can do that. Even if you can consolidate multiple conditions for treatment with one drug, a lot of times that's not possible. But if I had a patient with neuropathic pain, I might not start with an SSRI if I wanted to treat in addition to treat the depression in addition to neuropathic pain. So it helps direct where you're going. You do need to consider addiction substance abuse risk. And in the Scott Fishman book that's going to be mailed out to everybody, he has some really good references for tools and very nice approach to helping determine what to do with that information for patients once you assess that risk. Affordability. If you prescribe something for a patient that their Medicare Part D isn't going to pay for, like we're having a hard time getting Lyrica approved by a lot of companies, they can't afford it, they're not going to take it. And family members, it's really important to consider who's in that house. For the grandmother whose grandkids visit and her Lortab disappears after the grandkids go through the house, those are things to consider when you're picking meds to prescribe. So then looking within drug groups, if you decide that an NSAID is appropriate for the kind of pain that this patient has, you have advantages and disadvantages within the NSAID group. And advantages are listed on the left-hand side. They're good analgesics for that somatic skeletal muscle pain. They are anti-inflammatory, they're antipyretic, they reduce temperature. They're not a controlled substance, which makes them way easier to prescribe. The disadvantages are GI upset, ulceration, platelet inhibition. Patients are more likely to have ulcers and bleed on these drugs. They're more likely to exacerbate congestive heart failure. The most common reason for first admit to the hospital with congestive heart failure is they start taking an NSAID. Acute renal failure, that's often the reason for the first acute renal failure admit to the hospital in an elderly patient who gets the flu, gets hypovolemic because they're not drinking, because they're throwing up, and they take Advil for their aches and pains. They have ceiling effect. It doesn't make any difference if you take more. They're not going to work any better, and you're going to increase your adverse risk profile. They are very idiosyncratic. Just because one works for a patient or one doesn't work for a patient, doesn't mean that if you try 4 or 5 or 6 of them that you won't find one that doesn't, that you will find one that might work for that bony pain. There's some data for ketorolac in kidney stones, but that's about the only visceral pain data there is. They're not effective for neuropathic pain. 16,000 deaths per year associated with NSAIDs, and 2,000 hospitalizations associated with those GI complications, ulcerations, and bleeds. They are not safe medications. They can be purchased over the counter. When patients can't get enough pain medications, or they run out of, or we stop their Lortab or whatever, they often overdose on these NSAIDs. And the American Heart Association came out on the end of last year recommending for short-term use. The American Heart Association considers short-acting opioids safer for patients at risk for cardiovascular events than using NSAIDs. And if you're going to use an NSAID, when a patient at risk for cardiovascular events, you want to use naproxen, which is a Aleve, which has the highest GI ulcer rate of these drugs, or the non-acetylated salicylates, which I'm old enough to remember before Motrin even came on the market. The non-acetylated salicylates are like the selective COX-2s, the Vioxx, which you can't get anymore, and the Celebrex, which have decreased GI complication rates, no antiplatelet effect, so decreased risk of bleed, lowers cardiovascular risk like heart attacks and strokes than other NSAIDs, and I listed 3 of them there for you. So they're generic, they're cheap. Some of them are over the counters. The salicylate is prescription only, which means they'll get paid for by insurance companies. They're very good choices for patients with cardiovascular risks who an NSAID is determined to be a drug to treat the patient with. And I just listed all the NSAIDs out there that are available, because if one doesn't work, you can switch to another one. The selective COX-2s, which Vioxx and Bextra were withdrawn from the market because of, well, Vioxx increased heart attacks and stroke data. They were really heavily marketed. They are no better pain control. They are no safer for the kidneys. They do have decreased ulceration risk for the stomach, but they have increased cardiovascular risk. And so after 6 months of use, you're going to have an increased risk of heart attacks and strokes. And it gets up to about double what it would be. If you assess a patient's risk for a heart attack, you're going to about double it when you add Celebrex to it, long-term after 6 months. Here's another way to look at how to pick a medication. This is the World Health Organization published this 3-step analgesic ladder. Primarily it was published back, I believe, in 1990 for helping with cancer pain. Where do you start with cancer pain? And it just says, first step, mild pain, you use a non-opioid like Tylenol or an NSAID. And then when you step up to mild pain, you can add what they call mild or weak opioids, and plus or minus one of these adjuvants. And then when you get into severe pain, you go to your morphine, oxycodone, and so forth. So it was a thought process for when you start with less pain, and then you get to more pain, and you get to higher pain. If you think about it in reverse, generally in surgery and post-op pain, you're starting at the top. You're starting at the top with the morphine, stepping down to your Percocet or Talbot, coming down off of them totally. And so that was just another way that people were taught to look at how do you pick where you're going to go. Now this is what people come to us for. This is the sexy part of the speech. The opioids. And we have morphine, fentanyl, oxycodone, oxymorphone, meperidine, which we do not use. They're American Pain Society guidelines. And it's surprising to me the few patients who fail everything that think only Demerol works. It has a renally excreted neurotoxic metabolite that can cause seizures, coma, death. And so it should never be used chronically. It should never be used orally. Levorphanol, methadone, buprenorphine is on this slide. It's a little different, and I have a slide at the end if we get to it on buprenorphine. Hydrocodone, codeine, propoxyphene, tramadol, which tramadol, depending on who you talk to, it's a codeine analog, whether it's considered an opioid or not, because the DEA did not schedule it, and we'll talk about that in a minute. All of these drugs have the same side effect profile. Individual drugs might present with more constipation, less constipation, more itching, but they're all the same side effect profiles for all these opioid-related drugs. The only one patients do never get tolerant to is constipation. You always have to use a stimulant laxative. Well, not always. Once in a while, you have somebody with irritable bowel diarrhea type, and the opioid helps. But almost everyone needs a stimulant laxative scheduled. And every elderly person's been told never take stimulant laxatives every day because you get tolerant to them. But they do. While they're on the opioid, they need a stimulant laxative scheduled plus or minus the stool softener to prevent them from being admitted to the hospital with obstipation and obstructed bowels. You can expect most patients to have some nausea with starting all opioids. Pruritus and rashes are not allergies. These are normal pharmacological histamine release of the drugs. and so it's treatable. Confusion, generally speaking, they certainly can cause confusion, but also unrelieved pain causes confusion, and especially the hospital setting, unrelieved pain causes more confusion in elderly patients than opioids do. Sedation and respiratory depression, of course, is the big fear of respiratory depression leading to death, and that's why patients accidentally overdose. The cause of death is the respiratory depression. Patients are very, very individual in how they respond. There's at least 80 different variations of 2D6 that the liver makes and expresses. 10% of the population doesn't have the necessary 2D6 enzymes to metabolize codeine and hydrocodone to their active compounds. And this is what we always teach. And 8 to 10% of Caucasians, 3 to 4% of African Americans, up to 1% of Asians don't have it. And codeine truly is a prodrug. It actually has some antitussive effect as codeine, but to get to analgesic, you have to metabolize it to morphine. Okay? Now, hydrocodone in the lab, in data and so forth, you can show that it's metabolized to hydromorphone, and that poor metabolizers, which the 10% are, compared to extensive metabolizers, which only make 10% of the hydromorphone. And so the theory has always been that you have to also metabolize hydrocodone. But there was a new abstract out in May in which Abbott states they're coming out with a new 12-hour hydrocodone product that they show that there was no difference between extensive metabolizers and poor metabolizers, and so this may not be clinically significant on the hydrocodone. And tramadol has some data, and oxycodone has some data, but whether it's clinically significant or not, we don't know yet. Definitely with codeine. And then there's 7% of Americans who are ultra-rapid metabolizers, who really metabolize codeine fast to morphine. And there's a case report in the New England Journal of Medicine in 2004 of a patient who overdosed on normal doses of codeine for cough, low doses, oral cough, and he overdosed on it because he metabolized so much of it to morphine, and then he went into a little acute renal failure, so he couldn't excrete it. And he also had another drug on board that blocked the other pathway, 3A4, and he ended up toxic on codeine from very, very low doses. So you've got this whole picture of how people present and respond differently to drugs, and you think they're kind of crazy when they tell you some of these odd reactions they have. But genetically, how people respond to pain meds, not only with the 2D6 liver enzyme section, but they're showing differences in the opioid receptors in the brain. And some people will have more side effects and less analgesia to morphine depending on their genetic variation. And so people really do present differently. And so it does make sense to try two or three different opioids before you give up and decide they don't tolerate them. And these are all drugs that block 2D6. And so that complicates it. Even if you're an extensive metabolizer, if you take a drug that blocks it, you become a poor metabolizer. So opioids, first line for the nociceptive somatic type response in acute and cancer pain. There's very little efficacy and data to support long-term use in non-malignant pain, but we don't have a lot of better options for patients. And I quote a study that showed, there's one study that showed overall patients didn't fulfill any key outcome goals in this one big database. We taught, sometimes so much older, that there was a study way back in, in the 80s that showed that the percentage of substance abuse addiction was like less than 1% in patients that had opioids over 1 or 2 months. It was an acute post-op pain group that was in the hospital back in those days, like for a month after surgery. Now we're showing that substance abuse addiction rate is a lot higher in chronic non-cancer long-term opioid use, but it's very difficult to define substance abuse. Even addiction isn't defined the same. And so it's just, we know it's higher than 1%. Some studies go up to 61%. And what you do with that aberrant behavior is, some patients just need to be educated, and It's just an awareness that it isn't the same thing that we thought, that these drugs were not the absolute answer to all pain management that we thought they were back in the 80s. There's a lot of hormonal effects, there's complex immune effects. What we consider an opioid failure in a short little summary real quick would be that they continue to have really high pain scores despite the fact you've tried a couple different opioids and and you've escalated the dose appropriately. They continue to have significant side effects and want to continue the drug. That's very unusual. Decreased function or quality of life once they're on the opioid compared to previously. They used to work, they want to keep working, so they need their pain control, so you put them on the opioid and they quit working. Is not a good outcome. Continued aberrant behavior despite education. Everybody makes bad decisions sometimes, and just due to the lack of education, bad decisions. So you have to work with these patients, but if they continue to have aberrant behavior, we would consider that a failure. Now there's treatment strategies to avoid pseudo-addiction. I don't have very much time left, and so those slides can be used to look at later. Methadone is very difficult to dose. It's our most cost-effective long-term drug to treat pain. It's very effective. We talked about the NMD receptor antagonist piece. People keep thinking it might be better for neuropathy pain than opioids, but the few head-to-head trials I've seen with morphine and so forth show no benefit yet, so I don't know if that's clinically significant. There is some increased serotonin release and little mood alteration. That's why it's your drug of choice in a compliant patient with a history of abuse. And then there's some information on the half-life, how you dose it, huge conversion ratios. You do have this pocket reference in your packet because we don't have time to actually practice conversions, but it does talk about just guessing how much drug one person will need when you change from one drug to another is a bad way to go. It's better to at least look at these guidelines that give us a better suggestion. They're just guidelines. They're not exact science, but it's a better way to go than to just make it up. Propoxyphene we don't use, or almost never use. There is a huge amount of the CNS side effects associated with it, and there's a cardiotoxic, renally excreted metabolite that is dangerous, particularly in the elderly, and that's the little old woman. Every woman, 80 years old, who lives down the Bitterroot, I swear, has pink propoxyphene tablets in their medicine cabinet. There's advantages to combining drugs, but the dose-limiting factor for these drugs is the Tylenol, the ibuprofen, the aspirin, whatever it's combined with. It's not the opioid, it's what it's combined with that limits what you can give. Tramadol, because it's not scheduled, people think is safer. I've seen 4 patients who have grand mal seizures on this drug who never had a history of seizures before. So it's also got a ceiling effect. If a patient doesn't have enough pain control and they were non-compliant on Lortab or Percocet, guess what they're going to do on Tramadol? They're going to be probably non-compliant on Tramadol, and you raise your seizure risk. And buprenorphine is used now, since Montana doesn't have a Schedule I licensed heroin opioid treatment methadone clinic. This was designed for primary care to be able to help treat addiction in the community. And it decreases craving, it can work really well, it can also treat pain. And it does have a ceiling effect. Lots more doesn't give better pain control, doesn't give more euphoria, doesn't change mood. It can be very difficult to reverse. It's a partial agonist that binds very, very tightly to the receptors. And so if a person on buprenorphine gets into a car wreck, ends up in the hospital, in the ICU, and they're not responding to the morphine we're giving, and people keep escalating the dose, it's because the buprenorphine won't let go of the receptor sites. And it takes about 48 hours for it to give up. And then all of a sudden you've escalated the morphine to these big doses and the patient crashes. And it's going to take about 48 hours for buprenorphine to wear off. And so my end slide is, how did my pain-killing pill work out? Not good. As it turns out, ironically, it can kill you. Eureka, the cure for chronic pain.
Hold all your questions until the end. We're going to do question and answer for all of the speakers at the end. So if you've got questions, write it down. Our next speaker is going to be Dr. David Junker. Dr. Junker is a new addition to Missoula, just finished a pain fellowship in California, actually at the program where Dr. Fishman is the chairman. So I think that Dr. Junker put in a few good words for us and allowed us to get Dr. Fishman as the speaker. So thank you, David. You're welcome. Take it over.
We're just going to do a little quick change out of computers because I'm going to use the Mac.
Well, it's great to be here. I've been in Montana 31 days now. And let me ask everybody a question here. Most people here from Montana? So I was fly fishing up on Rock Creek. I like to fly fish. And I ran into my first black bear. Only black bear I've ever seen is in the zoo or on TV. And he came up out of the water and he just was kind of looking at me. And so I started yelling at him because I wasn't sure what to do. And then he started to charge me. So what do? Do you go like this? Or do you just cower like that? Cower? All right. I didn't run. I knew that. It is. There's a little hair raising, I'll tell you. So then I went to the sporting goods store the next day and I said, well, do I need a 44 Magnum or bear spray? And they said bear spray. But I don't know if that's true either. All right, I'm hoping this is going to work here. Okay, moving on. So really, I've been asked to talk about interventional pain management today and kind of what interventional pain physician can bring you. How many people are in primary care here? Are most people, big majority in primary care? So really kind of what I want to do is just paint a very big overview of what interventional pain physician might have to offer you and your patients and kind of tackle pain from a different direction. Just to start off, this is my dreaded pain patient, as I'm sure it is many of yours, right? The patient who's 10 out of 10 pain, nothing's helping them, they're smiling at you, and you can never figure out what's going on, right? This is like, what do you do with this? And even though I am an interventional pain physician, I do treat all pain, and I don't like to just stick needles into people and see what happens. And finally, really, you know, in the last 10 to 15 years, the technology has changed so much, especially with like fluoroscopy now, that we can really see where we're going with our needles, which allows us to be much more safe and more targeted in our therapies. And, you know, we don't have to wonder why this goat's sitting up here in the clouds, right? So, moving on, probably the most common referral that I see, and I think probably most interventional pain physicians, and probably a lot of the pain you see is back and neck pain. And the way I kind of think about back and neck pain, it may just be my own way, but I'll just kind of share with you how I kind of break it down in my own head. I try to look for pain generators, you know, what's causing this person's pain. So certainly the MRI imaging helps with that. So first of all, there's discogenic pain with you can have disc herniation, the bulges, the extrusions, and those things can obviously cause axial back pain, but it can also cause radicular pain down into the extremities. This is an image here. You can obviously see where the disc herniation there. Unfortunately, I can't use the pointer to point it out to everybody. The other thing that we very commonly see is patients with facet pain, facet arthropathy pain. These patients usually are going to present with axial back pain, axial neck pain. May have some radiation of pain in their their buttocks and down to their posterior legs, but not going to go all the way down the legs. This is just an axial image on the MRI here. It shows these facet joints where that arrow is. We call it the hamburger sign. Just demonstrates more hypertrophy in that joint. And then, of course, with facet arthropathy and a bulging disc and ligamentum flavum hypertrophy, you can get spinal stenosis, which we often will see in our elderly patients. Oops, sorry about that. And then the other thing is I just put down piriformis syndrome. I'll briefly talk about that. These are the patients that are going to present with sciatic type pain and may be referred for an epidural steroid injection, but actually what's going on is that their sciatic nerves are being irritated more by their piriformis muscle than it actually is coming from their back. And then, of course, sacroiliac joint pain is another generator, often more buttock type pain that patients can present with that we may be able to help them out. So the most common thing I think we get referrals for, mainly the bread and butter of interventional pain, is the epidural steroid injection. And really this can be very effective for patients who have degenerative disc disease that might have some inflammation back there, irritating nerves, irritating the spine. There's different approaches we can use. There's an interlaminar approach, which is more of a midline approach, as seen on this patient here. This is in the neck, obviously. This is someone who's had an anterior cervical disc fusion there. And we can target, sometimes we can target off to one side more than another, but in general it's more of a shotgun approach where you're getting the steroid in there and you're kind of spreading it out, trying to get both sides, just trying to get everything. And we can do this in the cervical, thoracic, and lumbar spine. The other approach, if patients have more, this is a thoracic epidural, and I'll just add here, this is the nice thing about thoracoscopy, is that not only can you take your AP image, but then you can flip to a lateral, and we can actually see our needle going right into the epidural space. We can inject contrast and see it layering out in the epidural space. So that's how we can be very targeted to see we're in the right spot, we know where we're going, we know our medicine's in the correct space. And so that can be quite nice. And this is a lumbar epidural steroid injection. But we can also target specific nerve roots. So if a patient comes in and they have more specific problems with arm pain in a specific dermatomal distribution or leg pain, we can actually do a transforaminal approach and really focus on that specific nerve. This is a left-sided S1 transforaminal epidural injection, so it's the S1 nerve root, and you can see we're lighting up that S1 nerve, but we're also getting epidural spread. We get a nice epidurogram. So usually this patients, if this is what the problem is, will have a good result. And this is moving up and doing a transforaminal at the L5 level. And again, these are really nice options. The caudal epidural injection is another option we can do. This is a image of the sacrum from a lateral view. There's an opening at the base of the sacrum where you can go through the sacrococcygeal ligament, and you can get your needle in there and inject dye up. You can see dye spread, that dark line going up. That's the epidural space. This type of injection is usually quite good for someone who's had back surgery before, they've had a laminectomy, they've had hardware placed in there. It's a little bit safer technique where you can get the medication up to the right level instead of risking having a wet tap or other type of complication because the anatomy has been changed in the back. So moving on, with facet arthropathy, those types of patients, like I said, they're going to have more, if it's back pain, they're going to have axial back pain. Usually, if you lean it back, externally oblique, and that's going to generate their pain. Kind of a classic finding, though. Sometimes the MRI is going to talk about hypertrophy. These types of patients, there's a few options. This is a oblique view. You can kind of see where the needle is there. That's actually the facet joint, and you can hopefully see them above. I don't have the pointer to show you exactly where they're at, but the two options are really to do an intra-articular facet joint injection where you place the needle into the joint. You can inject some steroid and local anesthetic. In my opinion, this may be arguable, but I think that's a very good technique for a younger type patient. They tend to respond pretty well to actually this type of an injection. Again, all we're trying to do is decrease inflammation, get them into some physical therapy, and hopefully it improves. For the older patients, there's other options. The other options are that you can actually denervate the joint. You can take away the ability of the body to sense pain in that joint. And the way you do that is to block the medial branch nerve, which is a nerve that comes off and goes to that joint. Its only job is to sense pain in that joint. So before you would go and actually ablate that nerve with using a technique called radiofrequency ablation, which is basically just placing a needle down where the nerve lives, stimulating it to make sure you're in the right place, and then using radio waves with a probe to heat up the tip of the needle and basically melt that nerve away. That's what I tell my patients anyway. We would want to do a diagnostic block first. So basically we'll bring the patient in, we'll do a diagnostic block, and we'll see how they feel. If they get a significant reduction in their pain, usually at least greater than 50%, then it would probably be okay to move forward with the definitive radiofrequency ablation. The reason I say I think this is better in an older patient, and I'm not going to say how old you have to be old, but is that these nerves will regenerate. And if you do this to a young patient in their 20s, you can really kind of run into problems where you're going to have to continually redo these injections. So that's why I'd usually go with the younger patient with an intra-articular injection. They do regenerate. Sometimes the pain comes back, sometimes it doesn't. Usually I tell patients, we like to get a year, sometimes 2. I've seen patients 5 years out. Sometimes it only works for a few months, but it's definitely a longer solution to the problem. This is a cervical intra-articular facet joint injection. This would be the medial branch blocks where we place the nerves and place the local anesthetic. It's just an AP image here, and this is in the neck. And this is an image here demonstrating the medial branch dorsal root. That's the nerve that we're targeting that would innervate the joint. Now, what about sacroiliac joint pain? Well, these patients are going to present with buttock pain. They may have some pain that goes into the posterior thigh. The way you can test that, there's several different tests you can use. You can use the Faber or Patrick's exam where you flex their leg, abduct, and externally rotate and see if you can reproduce that hip. There's things like the Gansling's test. There's several things that you can do. Imaging studies may show arthritis in that joint, that somebody may respond to that. A sacroiliac joint injection. So again, under live fluoroscopy, we can look at the joint, we can inject dye, make sure we're getting nice spread up the joint, and then we can inject local anesthetic and some steroid and see how the patient does. And again, any of these injections, it's really important to have these patients involved in a good physical therapy program to really rehab them and get them into the best shape possible. These injections work, but they definitely work better with other modalities also. If patients are getting results from the sacroiliac joint injection, but it's only lasting a few months and you've done like 3 or 4, well, then maybe they would be a candidate for to denervate the joint, again using a radiofrequency technique. Now, this is a lot of needle sticks here to do this procedure, and the problem is that with the sacroiliac joint, it's actually innervated anteriorly and posteriorly. So we can certainly denervate the posterior aspect, but the anterior aspect we really can't get to. So sometimes the results can be equivocal with this procedure. Just briefly talk about piriformis syndrome. Again, this is where the sciatic nerve runs, usually underneath the belly of the piriformis muscle. Sometimes if that gets irritated or injured, patients can present with sciatica that's not associated with their back. Usually they're going to have pain in the sacral notch back in their buttock area with radiculitis or radiculopathy type symptoms. There's actually been a cadaver study that shows that around 12% of the population actually have that sciatic nerve go through the belly of the piriformis muscle. So it kind of makes sense sometimes if that muscle's injured that you can get this sciatic type pain. Again, for this type of an issue, there are different ways to do this. We tend to use fluoroscopy. Many people just use an EMG guided technique where you can get into the belly of the muscle and inject local anesthetic and some steroid to try to calm things down. Some people will even use Botox to try to decrease muscle spasm in that area for piriformis syndrome. Complex regional pain syndrome, or RSD, is a very challenging problem to treat. The best shot at really dealing with this is treating it in the first few months. The first 3 months is going to be your best chance. Most people think it's a sympathetically mediated pain, and so the way that we can tackle that is actually doing sympathectomies, basically. There's certain ganglia that you can do. So for the upper extremity, you can do a stellate ganglion block, which is a ganglion that's located around C6 and C7. Here, where you come with a needle and you inject local anesthetic. Of course, we always use dye to make sure we're in the right place and not getting vascular spread. This is a patient here having a left-sided stellate ganglion block. And again, that's for an upper extremity complex regional pain syndrome. Does everybody know complex regional pain syndrome pretty well? Have most people seen that? Maybe not. Usually occurs after an injury or sometimes a surgery. They'll have allodynia or hyperalgesia. You touch them, they don't want anything touching their hands. A lot of burning pain. They'll have swelling, changes in color. In the later stages, you get atrophy, changes in your nails, you lose your hair in that area. It's a very devastating process. For the lower extremities, we can actually do a lumbar plexus block, and that's obviously in the lumbar spine, usually around the L2 or L3 area. There's a little bit more risk to these, some would say, and I think it's probably true. And the reason for that is you can see on this lateral picture here, the needle actually is going very far anterior, going anterior to the vertebral body. You can see where their dye is layering out there. Of course, there's big blood vessels here, like the inferior vena cava and the aorta, that you need to be careful of. But again, I think with the fluoroscopy, it really adds a huge safety factor to seeing where your dye is and making sure you're not in places that you shouldn't be. If those things aren't working, then there's certainly peripheral nerve blocks that you can do for the upper extremity and the lower extremity. I won't get into all the details on that. And oftentimes also you can try a beer block, and this isn't giving the patient a few beers to drink, but actually is a technique described by Dr. Beer, I believe back in the late 1800s, early 1900s. But what you do is you place a tourniquet either on the upper extremity or on the lower extremity. You exsanguinate the arm with a wrap, and you inflate the cuff, and then you can inject a large volume of local anesthetic through the IV that you've started into the extremity for about 30 minutes. And you can block the nervous system that way. The whole theory really behind this treatment is that you're trying to have the whole nervous system reset. And these patients are going to require several blocks, oftentimes maybe like one a week for 6 treatment, one every other week. That's assuming that you're making progress each time, obviously. Now the other sympathetic block we can do is a ganglion impar block. This is not the best picture, but this is actually your sacrum and your coccyx here from the lateral view. The easiest way to approach this is you can actually take a needle and you can go through the anal-coccygeal ligament, and which I think you can kind of see that needle, and then you inject dye, which is going to layer out on the anterior surface there of the sacrum and the coccyx. This is actually a good injection, not just for coccydynia pain, but for pains for rectal pain or perineal pain, that it can help treat these patients. Whether they have some weird neuropathic component that you can't figure out, sometimes it can be beneficial. And all of these sympathetic blocks are going to come back when I get into talking about cancer pain and cancer blocks. This is the type of blocks that we would do for that, and I'll get into that in just a minute. For postherpetic neuralgia, the pain that you get after a herpes zoster breakout, again, a very challenging pain syndrome to treat. Options for this, it's the most common place for this type of pain is in the thoracic area. Second would be up in the V1 distribution of the trigeminal nerve, but the thoracic epidural can sometimes be beneficial with local anesthetics and steroid. If that doesn't work, there's options such as intercostal nerve blocks, where you're actually blocking the nerves that run underneath the rib and that dermatomal distribution. And if that doesn't work and they're failing all conservative therapy, other options are to try a spinal cord stimulator. As far as neck pain and cervicogenic headache, a lot of cervicogenic headache comes from the neck. And I think some people tend to forget that sometimes. And there's also the other not very common thing, but I see it quite a bit, is greater and lesser occipital neuralgia. So pain here, back here in the occiput area, usually you can palpate back here in the occipital groove, and you can reproduce this radiating pain pattern. And that's actually a very easy thing to block with a local anesthetic and some steroids, and you can calm that type of headache pattern down. Other things are, if that doesn't work, this type of headache pain can come from the facet arthropathy pain, or usually often around the C2, C3 joint. There's the third occipital nerve, which will give off radiating branches up into this area, and you can block that. And if you have a successful block, then you can do the radiofrequency ablation procedure and ablate that nerve. This can be very successful. Again, then dorsal column stimulators, or the spinal cord stimulator is the layman's term, would also be an option for this type of pain. And I think the new advances in interventional pain management that you're going to see in the next 10 to 15 years, this is just my personal opinion, is that these peripheral nerve stimulators. And that's really in the last few years, especially with this occipital headache type pain, people are now starting to implant these electrodes underneath the skin, where you're stimulating these nerves, and then you implant a generator. And they're getting some good results, but I've seen this done. I haven't done it myself, but I have a feeling that this may be where we're headed in the future. And like I said, people are getting some good results. As far as joint pain, there's lots of options here. Certainly hip injections, knee injections, shoulder injections. Hip injections we can do under fluoroscopy. The other injections, obviously, you don't need to. We can use local anesthetic with steroids. and even very commonly Synvisc or Hyalgan, which is a viscous material to try to give some cushion in that joint for patients who have significant degenerative disease, usually more as a bridge to get them another year or more before they have to get a joint replacement. And I'm sure this is your favorite patient, as it is mine, the abdominal and pelvic pain patient. Very tough patient to treat, not only because it's hard often to find the pain generator, but there's usually a fair good amount of psychosomatic type issues that go along with this type of pain, so it can be very challenging. Some options would be to try a superior hypogastric nerve block. I don't think this is certainly the first thing I would ever jump to. It'd probably be one of the last things if I can't figure out what's going on. Again, this is just blocking not just the sympathetic nerves, but your nociceptive afferent nerves from the pelvis and the abdomen actually run with your sympathetic chain, so you can block those nerves with this type of a sympathetic block. Some people it's in the literature, have talked about spinal cord stimulation, even intrathecal pain pumps for this type of pain. But again, I think that would, for me anyway, would be more of a later resort or a last resort, or not doing it at all, probably actually. But it is described. This is just a superior hypogastric nerve block. So cancer pain, it's been touched on here before. Probably the most common thing people hear about is the celiac plexus block for pancreatic cancer pain. All of those sympathetic chains I just talked to you about that we can block for like complex regional pain syndrome or other sympathetically mediated pains, again, you can ablate those using alcohol or phenol, and get a longer term result than just a few hour block. This is really meant for the patient who has less than 6 months to live. The reason for that is that these nerves do regenerate also, and you can get a much worse pain when those nerves regenerate. But when it works, it can really be fabulous. You can decrease their opioids, they can be more awake, they can have a very good quality of life in that last several months. The celiac plexus block is, as I said, more for pain from the distal esophagus down to the transverse colon, so it covers a large area up here in the abdomen, the upper abdomen. The lumbar plexus neurolytic block would be more for extremity pain. Superior hypogastric would be more for pelvic pain, and the ganglion impar block would be for like rectal cancer or any type of perineal cancer. Now, if somebody has pain, they're going to have a 6 month or longer lifespan, then these people actually can do very well with an intrathecal pain pump, where you can actually inject multiple different kinds of medications, opioid, morphine, or clonidine, depending on what kind of pain they're having, actually into the fluid that surrounds the spinal cord. You could place a pump, and they can have a very good quality of life that way. The celiac plexus block, this is a celiac plexus block. It's a little bit more challenging procedure because there's two approaches. One, you can see how much further anterior that needle is from the other injections I've showed you, and that's because the celiac plexus sits in front of the aorta. So the one way you can do it is to go through the aorta. The other way you can do is to go what we call retrocrural and go behind the diaphragm. This is a transaortic approach here. And this is the Medtronic pain pump that you can implant. So myofascial pain. Myofascial pain, there are lots of options. Throwing darts at them, right? Trigger point injections, Botox, acupuncture, percutaneous electrical nerve stimulation. That's really just acupuncture and connecting that to a stimulator to stimulate the muscle. It's usually about a 20 or 30 minute treatment that you can do. These can be very effective for patients who actually have true trigger point pain. Not effective for like a fibromyalgia patient. In fact, you'd probably flare a fibromyalgia patient with a lot of this stuff. But for somebody who has a very, tight spastic muscle, you palpate it, you get a radiating pattern, they have a jump sign, those types of patients can actually respond quite well to this type of treatment. And finally, I'm just going to close with spinal cord stimulation. I talked very briefly about intrathecal pumps, but spinal cord stimulation, this is a type of therapy that's very good for neuropathic pain. Specifically neuropathic pain, and what you're doing here is you're swapping out one sensation for another. That's really the theory behind it, the gate theory, but you're stimulating the dorsal column of the spinal cord and you're giving a patient a paresthesia, they feel a buzzing or a tingling sensation, and you're trying to cover that area where they have pain. So if they have foot pain, you're trying to create this buzzing or tingling sensation in their foot where their pain is, and you're giving them that sensation instead of the pain. That's the whole theory behind this. The most common types of patients that we see that we would implant are people that have, failed back surgery. They've had back surgery, pain's not any better or it's worse. Complex regional pain syndrome is very common. Things like post-herpetic neuralgia would be other options. And there are other certain neuropathic pain states that we could do, but these are certainly the most common one. And that's pretty much it. I appreciate your time. I'll be happy to answer questions later or take questions in the back. Thank you.
We have one more speaker before we'll take a short break again. That speaker is Dr. Patrick Davis. Dr. Davis is a clinical psychologist that's worked with chronic pain patients for better than 15 years. He currently works here in Missoula, and we've asked him to answer the question that every patient asks, and that is, why are you asking me to see a psychologist? I have pain.
Sure. Thank you. And good afternoon. So I decided to organize this presentation around three main themes as best I could. The first is providing some information that might be helpful in terms of understanding the role that psychosocial factors play in the variability of pain experience across patients. We see patients who have very similar physiological status, but their subjective report of pain varies quite a bit. And psychosocial factors can go a long distance in terms of helping to understand that kind of variability. I also want to try to talk some about the role of psychosocial factors in the progression from acute pain to chronic pain. I think this is a particularly exciting area of interest and research and work that people are doing, and something that we can really, if we can put together programs that would be helpful in preventing that progression, that would be immensely helpful to people. And I think we know a lot about how to identify people who are at risk for progressing from acute to chronic pain. So we'll be talking a little bit about that. A lot of those factors, there's both physical factors as well as psychosocial factors that contribute or are thought to contribute to that progression. And then finally, I want to talk a little bit about the role of a psychologist in a multidisciplinary treatment team when it comes to assessment and the treatment of pain. And I'm going to try to break that down a little bit between acute, subacute, and chronic pain. So I'm going to go back to this definition that Dr. Rudin started with this morning, which states that pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. And I've highlighted and underlined specific words in this definition because I think they illustrate real nicely the multimodal nature of the pain experience. So yes, it is a sensory experience, but there are emotional or affective components to that experience. Whenever you experience pain, you're likely to have an emotional reaction of some sort. And it's interesting that in this definition they talk about this experience being associated with actual tissue damage or even potential tissue damage. Because one of the things that we find that's really important for some patients with pain is their anticipation of the pain that they're going to experience. It makes a big difference in terms of the actual pain intensity that they'll report. So if we can work with them around that anticipatory anxiety, that's something that we can do that will be very helpful both for people with acute pain as well as with chronic pain. And then I've also underlined the word described because I think it kind of gets at the evaluative or the cognitive component of the pain experience, what we think about the pain experience and what meaning that pain experience has for us. Again, if we have a pain and our interpretation of that pain is that there's something terrible happening inside our body or that it has consequences, long-term consequences for our quality of life or level of disability, our pain experience is likely to be magnified or intensified. By showing you that definition, I guess what I'm really trying to do is just to illustrate that in a comprehensive approach to pain management, we need to not just simply try to address the sensory components, but we need to try to address these affective and evaluative components as well. I work in the pain management program at St. Patrick Hospital, and for the most part I work with people who have chronic pain. But I want to talk a little bit today about acute pain and subacute pain too. Because on occasion I'm asked to help with people who are experiencing acute pain types of situations on an inpatient basis. And one thing that I really don't do much work with, but I think holds so much potential, is working with the people who might be in this kind of subacute phase, where we have the opportunity to maybe prevent that progression to chronic pain. So just as kind of an overview, I want to say with the people who have acute pain, there is a role for psychosocial or psychological or behavioral medicine intervention. And there's a couple of things that we can do. One thing that we can do is we can teach those patients coping skills. We can teach them how to get through those episodes of intense pain while minimizing their need for medications. And that's particularly important in situations where there's difficulty for one reason or another, providing the type of pharmacological intervention that the person wants. Another thing that I think is not really done very much today, but holds a lot of benefit, would be to screen those patients. If you have a patient who has an acute pain syndrome, and they're becoming kind of a problem patient for one reason or another, if we can screen those people to see whether or not they're at risk for development of chronic pain, we can then get them into intervention programs which may help them not progress onto chronicity. This is also true for the people who are in the subacute phase, people who've had an injury or a illness, and they're getting to the point where you're thinking, well, they really shouldn't be having pain anymore. It's not really chronic yet, but it's starting to look kind of questionable. These folks also, we can screen to determine whether or not they appear to be at risk for developing chronic pain. And if they do appear to be somebody who's at risk for that kind of progression, we can get them into some sort of interventional program, probably behavioral medicine type of program that may just be helpful in preventing the development of that chronicity. And then finally, behavioral medicine or psychological intervention, of course, can be helpful for people who have persistent pain. In that situation, we're going to be talking about teaching them coping skills, but we're also going to be talking about teaching them pain self-management skills as well. The pain self-management is more important for the chronic pain patient than for the acute pain patient, just simply because hopefully most of the people who have acute pain, the pain's going to go away and they're not going to have to worry about managing it day to day. But when the pain has become persistent, these people need to learn skills that will allow them to maximize their quality of life, minimize their level of disability, and in fact do some things that may dampen down the overall sensory pain experience as well. So that's kind of the overview of where we're going. Let's talk a little bit about this progression from acute to chronic pain, and then we'll come back and talk about specific coping strategies for acute pain, and then we'll move on to working with chronic pain. There's been some work that's been done and has been published in the literature with regard to the progression from acute to chronic pain. In particular, Gatchell published a theory back in 1991, which was composed of 3 stages. The first stage is a stage in which a person has the perception of acute pain and has natural sorts of emotional reactions to it. And as I said earlier, we all, to a greater or lesser degree, depending somewhat on our personalities and previous experiences, will have emotional reactions of one sort or another to an acute pain. If that pain doesn't go away, we start to develop or experience exacerbations of various psychological or behavioral problems. And these may be problems that pre-existed the development of the pain problem in the first place, and so they become exacerbated, they get worse. Problems with anxiety, problems with depression, if a person had problematic personality traits, but managed them reasonably well earlier on. All of these things can be exacerbated in the context of persisting pain. In addition, people may develop difficulties with anxiety or depression. They may develop interpersonal problems as a result of the persisting pain. And then the third stage, according to Gatchell's theory, is that these secondary kind of problems or exacerbated problems then sort of consolidate and become a part of the person's overall experience, their way of being in the world, so that they adopt or sort of accept this sick role. And a variety of vicious cycles then can develop. One example of a vicious cycle is someone who becomes depressed in the context of chronic pain. Well, if they become depressed, as Dr. Bradley pointed out just a little while ago, we know that lowers the pain threshold. People are more likely to feel pain. Their pain's going to feel more intense to them if they're depressed. Because they're experiencing more and increased pain, that's likely to amplify their depression, so you get this vicious cycle going. The same thing happens with anxiety. If you have people who are very worried about the meaning of the pain, very worried about their ability to cope with the pain and live their life in the future, they're experiencing pain that aggravates that anxiety. The anxiety also increases pain perception, but also contributes to the overall pain experience by creating muscle tension. And if their pain syndrome, the physiological component of their pain syndrome is such that muscle tension will aggravate, cause additional nociception basically, then that anxiety causes increased pain. The increased pain just contributes to more anxiety, and you get another of these vicious cycles going. And really there's multiple different types of vicious cycles that may develop for any particular individual, depending on who they are and how they're psychologically constituted. I was looking through a recent issue of the journal Pain and trying to put together this presentation. I thought I'd try to just throw in a few recent articles that kind of go to some of the topics that I'm talking about. And one of the articles that I ran across was this article by Casey and Greenberg, where they were looking at the role of various psychosocial factors in pain experience. And they took a bunch of people who were acute pain patients and collected some basic demographic data, background data on them, and then looked at them again 3 months down the road to see whether or not any of these variables had any predictive power. This is hardly new science. People have been doing this kind of stuff for many years now, so this is just a recent study that's consistent with the findings of many, many studies that have shown these kinds of things. But what these folks found was people who at baseline during the acute phase of their pain syndrome had a higher level of depressive symptoms, or people who had a history of cumulative trauma, and then people who had strong beliefs early on about the constancy or permanency of their pain, at 3 months later on were more likely to have higher levels of reported pain and also to have higher levels of disability. These authors also noted, because they looked at baseline pain intensity too, that baseline pain intensity was not a particularly good predictor of subsequent pain and disability, whereas these psychosocial variables were better predictors. Just to illustrate the value of these psychosocial values in understanding this progression to long-term disability and long-term pain, I've also included a reference here to the New Zealand Acute Low Back Pain Guide, which includes a section on psychosocial risk factors and the assessment of those psychosocial risk factors. Following a rather extensive review of the scientific literature, the folks who put this New Zealand guidelines group concluded that these psychosocial factors were extremely important to assess during the acute pain phase of the person's situation, in the interest of hopefully being able to prevent the development of chronicity. They identified a variety of psychosocial risk factors, which they refer to as yellow flags. This is oh, and by the way, I made some changes to the presentation, and so this particular slide is not in your handout, but if you're interested in getting access to this New Zealand Acute Low Back Pain Guide and the supplemental section on the assessment of psychosocial risk factors, the website that's displayed on the slide there will take you there, or if you don't want to write that down, my email address is on the very first slide in your handout, and you can email me and I'll send you the information. In any event, they identified these 6 major categories of areas, or 6 major categories of psychosocial risk factors which seem to be important, which seem to be documented in the scientific literature as being predictive of long-term disability and long-term pain. And within each of these 6 categories, there's multiple particular kinds of variables that you might look at. Just to give you a little bit of the flavor of that sort of thing, with regard to attitudes and beliefs about back pain, we already just talked about beliefs about permanence and constancy. There's also the belief that hurt equals harm. There's the belief that a person should not have to experience pain. There's a whole variety of maladaptive pain-related beliefs that people may bring to their pain situation. With regard to behaviors, has the person become extremely sedentary? Are they starting to demonstrate what we call fear avoidance types of beliefs and behaviors, which I'll talk about a little bit more in a minute? Are there compensation issues? Do they have a high level of distress? Are they the kind of person who, when they're faced with adversity in life in one way or another, tends to become very emotional, experience a lot of distress? Do they have a lack of family support or excessive family support where their pain behavior is reinforced? And do they hate their job? Or are there other kinds of job stressors that may be contributing to the situation? All of these kinds of psychosocial factors appear to be related to whether or not people go on to long-term disability and whether or not they may go on to experiencing chronic pain. So this New Zealand group actually constructed a questionnaire called the Acute Low Back Pain Screening Questionnaire, which you can find, they've got it reproduced in the same document. It's a very relatively brief questionnaire, and if you're working with somebody who's got some kind of acute painful syndrome and you have concerns that this may become a problem as time goes by, it might be very worthwhile to administer this questionnaire or another similar one that I'm going to tell you about in just a little bit to that patient. And if they score as at risk, referring them for some type of psychosocial, psychological, behavioral medicine kind of intervention designed to reduce the risk of chronicity might be a very useful intervention for that particular patient. Just a couple other studies illustrating the role of psychosocial factors in pain. Again, these are recent studies from the same or a neighboring issue of the Journal of Pain. And again, I'm just trying to illustrate that this is, there's an extensive body of research illustrating these sorts of things. And these are just some of the most recent articles. The Brown, Seymour, Boyle, L. Grady, and Jones article looked at the impact of certainty versus uncertainty in terms of how severe pain feels to people when they experience it. And they found that if people are experiencing real intense or real severe pain before they actually receive the painful stimulus, that they actually perceive the pain then to be more painful than people who don't necessarily don't have a high level of certainty about how painful that painful stimulus is going to be. This has a clinical implication from a behavioral medicine or a psychological standpoint, in that working with people, whether it's acute pain or chronic pain, if we can help them to reduce their level of certainty about just how horrible that pain is going to be, if we can convince them that, well, maybe it's not going to be that bad, and this particularly comes into play when we're working with people around this fear avoidance dynamic, we may be able to help people actually reduce or dampen down their pain experience, the level of pain severity, just through changing the way that they're thinking about the pain in terms of their anticipations. Gurji and von Korff published an article where they did an international study. They looked at a sample of about 85,000 people. This is a survey type of design. And they found that the likelihood of psychiatric diagnosis was associated with the number of pain complaints. So as the number of discrete pain complaints that the person has, their neck hurts, their back hurts, their leg hurts, and so on and so forth, the likelihood of a psychiatric diagnosis being present also increased. So there does appear to be a correspondence between whether or not a person has mental health problems of one sort or another, and whether or not they're likely to complain of multiple pain complaints. An interesting aspect of this study that goes to this issue of masked depression or of chronic pain as a variant of depression was that they found that this correlation held for anxiety disorders as well as mood disorders. And so their interpretation of that data anyway was that it kind of disconfirmed the masked depression hypothesis. They found that this correlation held for generalized anxiety disorder, social phobia, and post-traumatic stress disorder as well. And then one final illustrative study, Keeley and Creed recently published an article in which they looked at the relationship of anxiety, depression, fear avoidance beliefs related to work in particular, and back pain related stresses, and found that those things predicted impairment in physical health related quality of life, as well as the number of healthcare contacts. So all of these studies illustrate, I guess, two things. One is that these psychosocial variables appear to be very important in the progression from acute to chronic pain, and also appear to be very important in terms of the quality of life and level of disability of people who have chronic pain. The second thing they illustrate then is if we can identify those particular characteristics in patients that we're working with and design interventions to address those particular issues, we'll be providing a more comprehensive approach to management of their pain for them, and hopefully a more successful outcome for them. Okay, so let's back up a little bit and talk about psychosocial factors and acute pain. What do we know about it? Well, we know that negative emotional states increase pain perception. There's a robust body of research that has shown this to be the case. So if you feel afraid, if you feel angry, if you feel anxious, or if you feel depressed, or you feel some other undefined negative emotional state, your perception of pain is likely to be magnified. If you're calm and feeling really good and your pain's a 5, but then you get really angry or really anxious, and nothing changes in your body aside from that emotional reaction, you might report that pain to be a 7 or an 8. There's just that impact on pain perception. And then with anger and anxiety in particular, I suppose fear as well, there's also that muscle tension component that I talked about earlier. There's also cognitive factors that play into a person's perception of pain, the intensity of the pain that they experience. It's helpful to think of the nociceptive signal being evaluated against a background, and that background includes memories of previous painful experiences. So if I did something before, if I bent over to pick up something off the floor before, and it really hurt me a whole lot, now when I think about bending over to pick up something off the floor, even though the original injury may have healed, even though I may have engaged in some kind of strengthening program to strengthen the muscles in my back, because I just expect that to hurt so bad, when I bend over to pick it up again, it may hurt a lot worse than it would if I didn't have that expectation. Where we focus our attention makes a big difference on how much pain we experience. Dr. Rubin talked about putting the comedy channel on the TV in the inpatient rooms, and it can make a tremendous difference. Anything that can distract the person from paying attention to their pain can make a tremendous difference. Discrimination is a very interesting concept because I think sometimes people have difficulty discriminating between emotional pain and their physical pain, and it's like part of that symphony. It's like trying to figure out where the French horn is. You know, you can kind of hear it in there, you know it's in there, but you don't really know where it is. And you don't know if that sound's coming from the French horn or if it's coming from some other instrument. Meaning, expectation, self-efficacy, all of these are cognitive, and self-efficacy is, well, I guess it's kind of a cognitive sort of factor, that make a difference in terms of how the pain signal's processed as a part of that symphony. So if we want to provide treatment to people who are experiencing acute pain, to help those individuals, what can we do? We can provide them with some education about how pain works so that they understand that it's not purely the sensory experience. I used to teach people all the time about the gate control theory of pain, and I think that that's I imagine everybody's probably had some exposure to that, but if you haven't, it's a useful sort of teaching tool that explains how the ascending nociceptive stimulus can be mediated or blocked by descending stimuli descending signals coming down from the brain. Excuse me. We can help the person try to learn that they can have some control over their pain experience and increase their sense of that kind of control. And then we can also help them just to develop affective as well as physiological quieting capacities. And by that, what I mean, affective quieting is just settling down all that emotional distress that goes along with the pain. Another quotation that was displayed earlier was, "Thank goodness I finally realized that while pain may be mandatory, suffering is optional." It's all that affective component that brings so much of that suffering into the picture. And so if we can help people to learn to experience the pain and separate it from that emotional response and quiet that emotional response, that can actually dampen down their pain experience. Physiological quieting is just what we usually refer to as relaxation training. I kind of like the phrase physiological self-regulation a little better, but it's kind of jargony, unfortunately. But again, just teaching people to relax their muscles and to be really calm physiologically can also help them tolerate the acute pain type of situation. There are some other specific kind of coping skills that we'll look at in just a moment. In fact, here they are right now. other non-pharmacological self-management strategies for dealing with acute pain. And a lot of these things apply to chronic pain as well. But I'm so used to talking to people about chronic pain, I've had to kind of figure out how I can take some of the stuff from chronic pain and put it into the acute pain kind of situation as well. And there is a lot of overlap. So in terms of affective quieting, again, we teach people that they can do that they actually can settle down their emotional reactions, that they don't have to have all that distress. And we can teach them specific techniques that can help with affective as well as physiological quieting. And some of those things are deep breathing exercises, distraction, relaxation, guided imagery, or hypnosis. But in addition to just reducing the emotional response sort of directly, we can also get at the emotional response as well as the physiological response through a cognitive sort of approach. And people always talk about cognitive behavioral therapy for chronic pain. And so this is kind of a slide that sort of illustrates that a little bit. Because otherwise it's just CBT, you know, refer them for CBT. But what's that mean? Well, these are some of the things that CBT means. All of the affective quieting stuff there, except for education, is behavioral stuff. You're teaching people behaviors that are helpful. But you can also teach them to manage what's going on inside their head, the cognition, the thinking. And so one aspect of the pain experience that's been researched quite extensively is this concept of catastrophizing, which basically boils down to when something bad happens or you expect something bad to happen, you say to yourself, oh my God, this is terrible, I can't handle it, I don't know what I'm going to do. And there's a whole lot of distress that goes along with that way of thinking. So if we can identify people who catastrophize, we can teach them to decatastrophize. And there's a couple of good short questionnaires actually that have been developed by researchers who look at this sort of stuff that can help us get a hint about who might and who might not be a catastrophizer. Again, we were talking about certainty and uncertainty a little earlier. If we can reduce, or in some circumstances increase uncertainty, that can be helpful to people as well. And then again, helping them to increase that sense of control over their pain. A lot of people at baseline just, you know, they don't think that pain's anything. First of all, they don't understand that pain is multifactorial or as complex a phenomenon as it is, so we need to teach them about that. And once we teach them about that, we also teach them about the fact that given that there are all these different instruments in the symphony, we can take a few of those instruments out, that they can do that themselves. And by doing that, they have greater control over the pain. They can reduce the pain intensity. So I guess I'm jumping around a little bit here, but moving back from just talking about working with people who have acute pain to this prevention of chronicity issue again, I wanted to point out a couple of screening instruments that people can use. There is the instrument from the New Zealand group, and bear with me while I find my notes page here. The ALB-PSQ, which is the Acute Low Back Pain Screening Questionnaire, comes from that New Zealand group. You can look it up on that website that I displayed a little bit earlier. There's another one, I'm not sure how to pronounce the first word, I think it's Cerebro, Musculoskeletal Pain Screening Questionnaire, which again attempts to do the same thing, and that's the OMPSQ. And I have the citation, I can tell you where to get it if you want it. Unfortunately, it's not in your handout or on the screen. But again, you have my email address, so if you wanted to get that information, you could send me an email and I would pass that on to you. In any event, either of those questionnaires can be used with somebody who's got acute pain to try to get a sense for whether or not they're likely to progress into chronic pain. And if you use those kinds of questionnaires with your acute pain patients, you can refer them for the kind of thing, the kind of pain school program that we run at the hospital, which is really designed for chronic pain patients, but really could be very, very helpful for people who are in the acute stage to help them prevent them from moving into the chronic stage. In addition, there's a cognitive behavioral program that's been developed by Linton. And again, if you want that specific reference, I can provide that to you as well. He's developed a 6-week program that includes focus on education about pain, relaxation training, behavior and activity management, cognitive appraisal and belief, communication skills and assertiveness, and coping with flare-ups. So I assume, you know, each week focuses on one of those things. The segment that focuses on behavior and activity management can again help with the fear avoidance issue. The section that focuses on cognitive appraisals and beliefs can help with the catastrophizing and with the maladaptive beliefs that are noted on the slide. Let me say just a word about fear avoidance, because I've said it several times, and if you're not familiar with that particular concept, it's just the idea that when you have pain, you may be afraid that it means that something terrible is happening in your body, so you better not do anything that's going to cause that pain. That can be a real problem when you go to some kind of functional restoration program or physical therapy program, because the physical therapist asks you to do stretching or strengthening or range of motion things, and you're reluctant to do them because you think that it's going to blow a disc out or do some other kind of terrible thing to your body. Again, we want to be able to identify people who have that kind of fear because they're going to avoid engaging in the very kinds of activities that may be restorative for them. Again, we have questionnaires that have been developed by these researchers that help us to identify who's high in this area of fear avoidance. And so if we identify people who have that, we can build that into their multidisciplinary plan. I'm down to 3 minutes, so I'm going to cruise right along here. This is a slide that just illustrates some issues that may be premorbid or comorbid that may contribute to magnified or exaggerated pain perception, may contribute to the development of these kinds of vicious cycles that perpetuate the pain experience or make the pain experience worse than it has to be. I don't really have the time, I guess, right now to explain some of these Greek words or Latin words, and some of those things are kind of more old school sort of stuff. But any of these kinds of things may contribute to a more complicated course of treatment for a patient who has pain. And as such, if they're present, the overall treatment plan may benefit from the involvement of behavioral medicine or mind-body strategies. So why do people who have chronic pain get all these secondary kinds of problems, these vicious cycles going? Well, it's helpful, I think, to think about the impact that chronic pain has on a person's life. And this is just a list of the kinds of changes that often take place in a person's life in the context of chronic pain. And if you stop and think about it, if I had chronic pain and these things started happening to me, would I be terribly surprised if I developed fear avoidance or depression or anxiety? Maybe not. So as a psychologist or behavioral medicine specialist, when I do an initial evaluation as a part of our overall multidisciplinary treatment program, these are the kinds of things that I want to assess. I'm very interested in the onset of the pain syndrome, in particular because of the possibility that there may be a post-traumatic kind of anxiety sort of thing going on associated with what happened to the person at the time of the injury. I think that's often overlooked. I think we all know that this history of abuse and trauma is very important, and in fact there's research showing that early abuse and trauma may result in some of these kinds of changes to the way the central nervous system processes stimuli, which makes people, on the one hand, have more difficulty coping with any kind of distress, and on the other hand, may magnify the pain experience. So we can treat people from a behavioral medicine standpoint in group treatments or in individual treatment. Sometimes we have to identify people who are not very motivated to participate in this approach. We think of it as a self-management approach, and a lot of people want to just be very passive, just give me my pills. And so we want to identify those people and not waste a lot of resources on people who aren't going to benefit from it, but rather track them into a different sort of intervention that's designed to increase their level of motivation. Again, there's this extensive literature showing that cognitive behavioral therapy is helpful in the treatment of pain. In Morley's meta-analysis in 1999, he commented that recently one reviewer, happened to be Loser, regretted that cognitive behavioral therapy is not provided routinely for chronic pain sufferers, rather than medical and physical interventions for which there's actually less evidence of efficacy. So, I'm probably a minute over time now, so I'm just going to come back to the presentation objectives. I hope in this brief half hour we've been able to illustrate some of the psychosocial factors that contribute to the variability in the pain presentation we see across patients who have similar physical findings. I hope I've conveyed some information that helps understand how psychosocial factors may contribute to the progression from acute to chronic pain. And I hope you've got a little insight into the behavioral medicine approach to assessment and treatment of acute, subacute, and chronic pain, particularly in the multidisciplinary setting. That's the end. There's my email address again. If I told you teased you with some information that you want some more about, that is in your handout. Thanks so much.